Much, Chairman. Good afternoon, colleagues. With permission of the Chair, I'd like to change one word in my title. Oh, and if I can move forward. There we go. Because I believe that you should look at cardiovascular events and not just the heart. Anybody who's worked with me in London and then in Houston will know that I play great store in looking at the whole of the fetal circulation. Now, I think one of the most useful things is that discordance is rare in monochorionic twins. And when we looked back at data just at the turn of last century, we found that cardiac valve measurements and their Dopplers were virtually identical in uncomplicated monochorionic twins. So this leads us to conclude that discordance in intertwin pair cardiovascular measurements might be a very useful marker for developing complications and being able to spot them early on. Just briefly to talk about congenital heart disease, and then I'm going to leave it, it's important to recognize that in contrast to the 4 per 1,000 cases that you'd get by screening a singleton population, about 4% of monochorionic twins will have some sort of congenital heart defect. Usually they're discordant for heart defects, but there have been reports of concordance for hypoplastic left heart syndrome, and that is well known. You'll probably find that you see more cases involving pulmonary valve disease than any other part of the heart, and in fact, in 12% of ex-recipient fetuses, we see an issue with either the pulmonary valve or a secundum atrial septal defect in childhood follow-up studies. So this is a little graph of all the complications of monochorionicity, or almost all of them. Some of them I'm not going to deal with. I'm going to try and just concentrate on the most important ones in the interests of time. So I won't be looking at TRAP, which Kurt dealt with very nicely on Sunday, or cord entanglement in monochorionic monoamniotic twins, because I don't think the cardiologist has anything really to add to the cord entanglement story. I think that before you go to look at what might be altered in twin-twin transfusion syndrome, it's important to discuss and to think about what is the likely mechanism, what is the sequence of events, so that you know what you should be looking for and be able to spot things early on. We've long known that the placenta is an important part in releasing vasoconstrictive substances, and that the donor kidneys respond to this with activation of the renin-angiotensin-aldosterone cascade. The donor will produce endothelium, which goes across to the recipient. And the very first sign, probably in the recipient, is an increased impedance, manifest by hypertension and altered ventricular strain. If you have increased impedance, it's much more difficult for your heart to fill, and therefore you get an increase in left ventricular end-diastolic pressure, and as this impairs filling, your atrial pressures increase, and it's more difficult to have the normal right-to-left atrial shunting. And this begins to this leads to things that we recognize quite easily when we're looking at the fetal circulation, and that is an abnormality of DV time intervals. It's only after these are abnormal that you really get the signs that we all used to think of in the early 1990s as being the cardiac signs of twin-twin, which are right ventricular volume loading, tricuspid regurgitation, ventricular hypertrophy, and of course an increase in the myocardial performance index. But it's the earlier signs that I think we should be interested in these days, and is what I'm going to concentrate on. I thank Christoph for a few of these slides. He's going to recognize some of them. And there are 3 parts to the circulation that we can usefully consider. There's preload, cardiac function, and afterload. And as I've just mentioned in the cascade, they probably occur in reverse order, in that you get the afterload occurring first, then cardiac function, and then alteration in preload. But really, it depends on how easy it is to detect these things. If you were looking at afterload in an adult, you'd measure their blood pressure, you'd look at other sort of vascular parameters. But we can't do that easily in the fetus. If there's tricuspid or mitral regurgitation and we can get a good quality regurgitant envelope, we can estimate blood pressure using the modified Bernoulli equation, which I'm going to mention a little later on. I don't think cardiac output measurements are reliable, reproducible, or are a good representation of afterload. I've spent many years calculating indexed cardiac output for recipients and donors, and in all of our analyses, they don't help until you get to stage 4. One thing that Christoph did when he was with us in Houston was to use speckle tracking and look at the area change in the aortic in the area of the aorta, in the transverse part, in the thorax, and it's the aortic fractional area change. We correlated this with an instrumented lamb model and found it was a very good surrogate for blood pressure. So if we were to be able to do something automated, this might be something helpful for us, but it isn't as yet a clinical tool. The literature over the last 20 years is full of people trying to modify the Congenital classification, often by using various ratios in the ductus venosus and in the hepatic and inferior vena cava. They look for the presence of umbilical venous pulsations. The cardiologists look at the time it takes to fill the ventricle with tricuspid valve inflow relative to the cardiac cycle, and that's a useful measure. And we've all looked at the myocardial performance index many times, trying the modified versions, automated versions. So these are some things that are that have been tried to look to predict outcomes based on the modified Congenital classification. It doesn't really seem that any of them are very successful, and so perhaps we need to look somewhere else. One of the first things I think we need to try and work out is this early twin-twin, or is it selective growth restriction? And I believe that looking at the ductus venosus profile, and again, thank you to Christoph for these lovely cartoons, is a very big help. How does it tell us what's going on in the fetal heart? Well, we should look at the atrioventricular ring. And in systole, the AV ring moves down towards the apex of the heart. And as it moves down, it decreases the atrial pressures and sucks in flow through the DV to fill the heart. And this is responsible with the first part of the wave, the early part of systole. During isovolumic relaxation time, the pressure increases in the atrium as the AV valve comes back up from the apex towards its resting position, and less flow comes through the DV, and that gives us this decrease in velocities and the V wave. Once the AV valves open, again, the ventricles are filling in the early stage of diastole, and this sucks blood again in through the DV towards the heart and gives us this peak diastolic flow, the early filling time, and we refer to this as the DV early time, and we usually measure it as a %. And then the last part of the cardiac cycle is when the atrium contracts, they increase atrial pressure, again reducing the amount of flow in the DV towards the heart. And that gives us this final deceleration curve, which ends up with the nadir, the lowest part, the lowest velocity in the DV waveform, the A wave. So it's all pretty straightforward, and we're able to get good quality DV recordings. And you can look at either the time intervals, take the integral under the waveform, or look at the peak velocities of the 4 waveforms I've just described. So during biweekly surveillance of monochorionic twins, you're getting a beginning of discordance of fetal size and fluid volumes. It doesn't satisfy Congenital stage 1, so what are you going to do? What is the best thing to look for? Well, I suggest these DV time intervals. It's not a new thought, Back in 2007, Bensouda and the group from Jean-Claude Furon in Montreal published a paper where they looked at a small cohort of early emerging twin-twin and those with emerging selective growth restriction. They made the measurements in the same way, but they used absolute measurements in milliseconds, and they concluded that there was no inter-twin pair difference between the bigger and the smaller twin in those with selective growth restriction, but when they looked at those that went on to develop twin-twin, at this early stage, the recipients had significantly shorter total and early ventricular filling times. We repeated this in a study in Houston with a larger group of patients, almost 150 monochorionic pregnancies, a third of whom were either pre-twin-twin or monochorionic controls. And we could confirm that this was indeed the case. We looked at all the various parameters, and Christoph did a ROC analysis and found that the best area under the curve was actually for the velocity time integral of the filling time, but we liked using the best differential was in fact the early filling time percent. And we recommended to our team and in our publication that we should measure the early filling time as a percent, perhaps even during surveillance of these twins. We just calculate the recipient and the donor filling times, and an absolute difference more than 3.6% is very indicative that twin-twin might be developing and that they should be referred to a centre for expert surveillance. So we have some idea that twin-twin is developing, but is it really twin-twin, or is it structural heart disease? That's the next thing that I always try and exclude when I'm looking at a set of twins. We talked a little about congenital heart disease right at the beginning, and pulmonary atresia, intact ventricular septum, accounts for only about 3% of congenital heart disease, but it's fourfold more common in monochorionic pregnancies, whether or not they have twin-twin. And it can be very confusing. They are both characterized by AV valve regurgitation, ventricular hypertrophy, an increase in the tie index, and absent or reversed end diastolic flow in the DV and the umbilical artery. And in fact, these parameters have been used by Tim Crumpleholm's group to develop the Cincinnati modification of the Quintero staging. And they've upstaged in about 60 to 80% of cases, stages from 1 up to 3A, B, or C, resulting in more cases being suitable for laser. So what are the tips to try and differentiate between these two phenomena? Because it isn't always straightforward. So I would recommend, this is a 20-week fetus, MCDA pregnancy with tricuspid regurgitation that you can see here. If you look at the grey scale, you can see the right atrium is a bit enlarged. There's a bit of a left axis deviation. That's a little bit of a clue. If you then go up towards the 3-vessel and tracheal view, the right outflow tract shows some reverse flow in the arterial duct. And then in a sagittal view of the heart, we can see that there is pulmonary regurgitation shown in red here. So the differential diagnosis here is this reversed circle physiology where everything is going backwards through the right heart, or is it pulmonary atresia, intact septum? Well, perhaps the Doppler might help. So in this fetus, the waveforms showed nice biphasic filling of the right ventricle. The TR jet, which is not shown here, was about 3 meters per second, indicating preserved right ventricular function. And the pulmonary regurgitant jet, we could see there was some forward flow, was again just over 3 meters per second. So this fetus has critical pulmonary stenosis and not twin-twin transfusion syndrome. So putting together the images and the Doppler and all the other variables that are going on with amniotic fluid measurements and bladder or no bladder in this smaller twin will hopefully give you an answer. But for those of you who've seen Pirates of the Caribbean, you'll know that there's a code, and that when the pirates come to obey the code, they say, well, they're just guidelines, really. So I'm just going to give you a couple of slides in this where I think if there's a crossbite, it's not likely to be the diagnosis or helpful, and if there's a tick, it's a little bit more likely. There's never an absolute in this. So is it twin-twin or critical pulmonary stenosis? I think if you've got high-velocity tricuspid regurgitation, it's more likely pulmonary stenosis or atresia. If you have a dysplastic tricuspid valve, it's more likely to be structural heart disease. And so if the right ventricle has a smallish cavity, very filled in, again, it's much more likely to be pulmonary atresia intact septum. The presence of pulmonary regurgitation is probably more common in twin-twin transfusion syndrome. Both have reverse flow in the duct, both have increased tie indices or myocardial performance index. Both of them will have absent or reversed end diastolic flow in the DV and sometimes in the umbilical artery. I think in twin-twin, they're more likely to have cerebral steal. When that flow is all backwards, it takes blood away from the middle cerebral artery, and looking at the brain is useful. And looking at the left heart function in twin-twin will show reduced MAPC and left tissue Doppler indices that you won't find in early second trimester pulmonary atresia. You do get poor function later on, but usually not as early as that. So those are my tips for differentiating the two. But as we heard on Sunday, we've got very successful treatment for twin-twin. Eve told us all about the high dual survival rates. So why do you need a cardiologist? You probably don't. Why do you need a pre-laser assessment of the heart? Well, I think number one, to make sure it is twin-twin and not pulmonary atresia. And secondly, to help refine which pregnancies need more careful follow-up in fetal life and after the babies are born. And your cardiologist should be able to guide you in this way. So we have always looked at pre-laser indices, cardiac indices in these monochorionic twins. So we've looked at preload, we've looked at afterload, and now cardiac function itself. So we recently published on 145 monochorionic twins, with 26 of them being uncomplicated controls. Half of them were, or just about half, were stages 1 and 2, and the other half were stages 3 and 4. And we looked at the usual suspects, MAPC and TAPC, MPI, tissue Doppler. We derived filling indices from using inflow Doppler over the tissue Doppler E over E prime. And if there was a good regurgitant jet through the mitral or the tricuspid valve, we would estimate blood pressure. And I promised I would just go through that with you again. And that is 4 times the maximum velocity squared, giving and adding on a small amount for right or left atrial pressure. And I've included usually something like 4 millimeters of mercury. So you can convert your peak velocity to an estimated fetal blood pressure. So these are the Doppler waveforms that you will all be familiar with. You can use ordinary Doppler, or you can use tissue Doppler for getting the myocardial color to use the tissue Doppler. In this particular baby, the tricuspid regurgitant jet was 3.3 meters per second, which gives a blood pressure of 48 millimeters of mercury in an 18-week fetus. Mean blood pressure is about the same as gestational age. So in an 18-week fetus, the blood pressure should be something in the region of 18 or 20 millimeters of mercury, not 48. So that gives you useful, interesting information. But just to summarize what we found, in all stages of twin-twin, 1 to 4, we showed inter-twin pair differences in the left heart. So there was a significant increase in the left MPI and the filling pressure of the recipient twin compared to the co-donor at all stages, early to late. So that is something that's useful. The recipient systolic velocities were only reduced later on, stages 3 and 4. When we looked across the Congenital stages, we found that we only found differences later in the Congenital staging. So the right heart filling pressures were increased in the recipient in stages 3 and 4, but nothing was found early on in the Congenital staging. And estimated blood pressure was elevated in 11 of the 14 recipients where we had good quality. And the median was 42 millimeters of mercury. And these fetuses were 18 to 20 weeks. So very high blood pressure. So just to summarize those, what do I do? What do I think is useful? Well, measuring TR and MR peak velocity, looking at the inflow duration, that E and A wave over the whole cardiac cycle. I don't do fractional shortening. I haven't done that for years. The tie index may be useful and is altered early on. I don't look at the thickness of the walls. I do note reverse ductal flow because that has implications for perinatal management. I don't measure I wouldn't recommend having to measure cardiac output or maximum velocities through the aortic and pulmonary valve if you're happy there isn't pulmonary stenosis. I do recommend precordial venous Dopplers and middle cerebral artery Dopplers and to look at the filling pressures. TAPSE and MAPSE were not that useful until later on in pregnancy. So although it's a nice, easy, reproducible measurement, it may not have a lot in terms of prognostic power. I can hear you all saying, what about strain? Everybody's publishing on strain. This is difficult. We've looked at strain over the past few years to try and find its role in fetal assessment and particularly in assessment in twins. Its problems are that it is offline analysis still, and you still have to use a manual adjustment of the endocardial border. There is a lot of variability, and we're still not so sure which is whether that's due to inter-observer variability or physiology, whether it reflects true pathophysiology in the changing circulation. We've just finished a study which was blinded of 150 monochorionic pregnancies studied throughout their surveillance when we separated the twin pairs, blinded the analysis to twin pair identity and outcomes, and that will be published soon. It'll be interesting reading, I hope. I'm not going to go through TAPS. That was dealt with on Sunday, just to say, look at the MCA peak systolic velocity. The heart may show that there is some right ventricular dilatation and there's regurgitation, and often physiological pulmonary atresia, which resolves completely within a week or two. What about the responses to laser? Well, usually it's good news. The right and the left MPI decrease. In the donors, you get evidence that there is increased forward flow from the placenta through the umbilical vein, MAPSE and TAPSE, and the systolic tissue Dopplers increase. The filling pressure and the cardiac output increases, but it's not all good news. This fetus here, you can see this ex-donor has tricuspid regurgitation and pulmonary regurgitation with reversal of flow in the arterial duct. And we've long known that the heart can become dilated with this increase in flow in a vasoconstricted donor fetus until the circulation settles. The usual tips are low velocity TR and physiological pulmonary atresia. You can see here this fetus, the MCA peak systolic velocity became normal after laser, but there is low velocity tricuspid regurgitation, bidirectional flow across the pulmonary valve, high PI in the DV, and umbilical venous pulsations. These babies usually get better. So it's not all bad news. Some things that I used to see very frequently in the old days, such as reversed or recurrent twin-twin, we don't see anymore. But as Eve told us, there is some concern about neurodevelopmental outcomes in twins that have undergone the Solomon procedure. Maybe it explains some world events. And the very good news is that if you're looking at that children who have survived twin-twin, their cardiovascular outcomes are very good and their blood pressures seem normal. So hopefully their outcomes are good in the long term. Thank you.
Well, thank you, Helena, for that excellent and highly sophisticated lecture. Did I get it right? I'm a little bit surprised about your distinction between pulmonary stenosis and TTTS, because we see cases at stage 3 or stage 4 with high drops where we have pulmonary regurgitation, pulmonary atresia, stenosis, and even reversed circulatory, I would say, pathophysiology. It's not really physiology.
Yes.
And you have the typical signs of twin-twin transfusion syndrome, massive polyhydramnios and stuck twin.
Yes.
So are they different entities, or is that a combination then, or what's first?
Well, that's a very good question, because I've certainly seen pulmonary atresia in monochorionic twins very early on, and then they have gone on to develop twin-twin. So if you have florid signs that there is twin-twin, yes, you're absolutely correct. And the other signs may or may not get better. If you have reverse cycle physiology, it will often get better over a period of weeks and months in utero. But postnatally, you may have to balloon the pulmonary valve. There may be residual damage from these flow patterns. And I think we don't know that there must be something genetic that hones in on the pulmonary valve to create this problem. What I was trying to say was, if you had, say, selective growth restriction with a little bit of discordance in fluid, but you had pulmonary atresia intact septum, if you're using the Cincinnati upscaling, you may then say, well, this looks like pre-twin-twin because we've got a little ollie-poly, but it doesn't satisfy the criteria, but we have the heart issues. I don't think that's true. I don't think that means that it is going to get better with laser. I think you have primary cardiac disease then. Yeah. And that's quite difficult.
So these could be the cases where pulmonary stenosis persists even after laser, because in about 1/3 to 40% of cases we have, it's not spontaneous, but remission of the reverse flow in the ductus arteriosus and the pulmonary trunk within the first days after laser, sometimes the next day. But how come that happens so fast?
It's a miracle, isn't it?
It's a miracle, yeah. We still have miracles, that's fine. Okay, there are questions from the auditorium, please.
Monique Haak, Leiden, the Netherlands. As being a fetal cardiologist and a fetal surgeon at the same time, I am tremendously frustrated by unexpected fetal death directly the next day after a laser. And thinking of interventions to prevent that, mainly in the direction of fetal balancing, maybe with drugs before a laser to balance the hemodynamics. Do you think there is some way with cardiac assessment to predict the cases that will show unexpected fetal death after a laser?
Well, I know Kurt's group looked at the DV time intervals and described that if the donor had altered systolic indices, so that S-wave and the deceleration, that in their cohort it could predict death of the donor in the next day or so after demise. There weren't many of them. I think it was 5 or 8, if I recall. So that may help, and certainly looking at the middle cerebral artery may also help tease out those babies who are not compensating well before you even do laser. I'm not sure that any cardiac parameter per se is going to help you, because I think they all depend so much on preload and afterload. You're better being able to measure those parameters more.
But what do you mean exactly with unexpected fetal death after laser? Because we do have this imbalance in placental sharing, and we know that if there's a small donor combined with selective IOGR, there's a 50% risk of death in this. So this is not really unexpected.
No, that are not the unexpected cases. And I published myself on this topic as well. So I know the risk factors which increase your risk. But it would be, but you have TTTS twins who are balanced in growth, balanced in all the parameters that you see, and you diagnose your TTTS quintero 2 or 3, and then you have a successful laser, a good fuse, fast procedure, and still there is a few percent in the first week after the laser that mainly the recipient dies. And I think that is cardiac adaptation or adaptation to the new situation, but we don't exactly know what is happening.
I completely agree with you. That's very frustrating, but the incidence that happens is quite low.
Yes, it is.
And it happens also without doing a laser in stage 1 TTTS. Yes. So stage 1 TTTS is already very dangerous. And we don't know why it happens, but
being
it
a
happens.
monochorionic is dangerous.
Yeah. Greg?
Lena, thank you. That was great. Can you comment? We've seen a number of cases where we have twins that are followed meticulously in really good hands that are stable every 2 weeks. And then usually twins that are the same size in later gestation, all of a sudden one of their cardiac functions goes off the table within days sometimes. And when we do a laser, it recovers equally rapidly. Can you give us any thoughts on the why?
Have you any clues from looking at the placenta after the delivery? Because, I mean, sometimes people have postulated thrombi, anastomotic thrombi, something that suddenly throws the balance off.
We haven't seen that, but what has been consistent has been that these have been AGA twins. There's been no growth discordance, an equally shared placenta. And it's something we don't see with growth-restricted twins, where one twin is growth-restricted. But the remarkable thing is they deteriorate rapidly and they recover rapidly.
Yes. It's a very fast emerging disease, though, isn't it? And that's why I think looking at the DV time intervals, incorporating them into surveillance, may be something that picks those cases up a bit earlier than you see clinically, because by the time the heart looks bad, it's been going on probably for a little while.
Okay, in the interest of time, we have to stop now, but you can see there are still problems to solve, and it's a very interesting discussion, and I think we will hear more about those particular problems in upcoming conferences.